Welcome my colleagues and my dear students. Now we are speaking about a third cardiac property, which is the excitability. As we know, we have four cardiac properties: the rhythmicity, the ability to generate nerve impulses; second, conductivity, the ability to transmit it; third, excitability, so that when the impulse reaches the contractile fibers via the conducting system, the contractile fibers respond by generation of action potential. And finally, the contractility, and we are now discussing the concept of the excitability. Look at this picture. You will find many shapes of action potential depending on the site of record of the action potential. So there is no constant shape for the action potential. It depends on the size, on the nature, on the electrical channels that are present. Here in the nodal tissue, you will find action potential that consists of a rapid depolarization and rapid repolarization. In the atrial muscle, you will find a plateau. When you study the action potential in the conducting system, you will note that the plateau period is prolonged. Also the same in the contractile fiber. Here we are studying the action potential in the contractile muscle fibers. It consists of rapid depolarization followed by a process of repolarization. First, there is a phase of very rapid depolarization, very fast depolarization. Then the process of repolarization has three phases. First, early partial repolarization, then we enter in a phase of plateau, and finally repolarization returns again rapidly. We have these phases: the phase of rapid depolarization, phase 0, the phase of early partial repolarization, phase 1, the plateau, phase 2, and late rapid repolarization, phase 3, and finally phase 4. Phase 0 is caused by rapid sodium influx via fast sodium channel. The process of partial repolarization has two causes. First, potassium efflux as the role of repolarization on all tissues. We have additional cause here, which is chloride influx. Then we enter in a stage of plateau, and its cause is the opening of a special type of channels for the cardiac muscle, which is called L-type calcium channel. When they open, plateau starts. As long as they are opened, plateau is present. At the end of plateau, they close. When they close, the plateau ends, and the process of repolarization returns rapid again. So we have four apparent phases for the action potential, followed by a state of complete repolarization. Phase 0 caused by rapid sodium influx. Phase 1, early partial repolarization, chloride influx and potassium efflux. Plateau, which starts with opening of L-type calcium channel and ends by their closure. And finally, there is exaggerated or increased potassium efflux causing final rapid repolarization, and phase 4 is the phase of complete repolarization. What is the relation between electric excitability and the mechanical changes? First, regarding the relation between mechanical changes and the electrical changes. What we studied, the action potential is the electrical changes. The mechanical is the systole and diastole of the heart. The first point is that mechanical changes starts just after the electrical. The second point is that the mechanical has a time that is about 1.5 times the time of the electrical changes. The third point is that the peak of systole is correspondent to the end of plateau. This is the classic action potential in the cardiac muscle, and this is the mechanical changes. It is composed of systole and diastole, and comparing the two curves, the mechanical with the electrical, we find that the systole is corresponding to phases 0, phase 1 and phase 2, and the systole reaches its peak by the end of plateau. Regarding the relation between diastole and the electrical changes, we will find that the phase of rapid repolarization is correspondent to the first half of diastole, and then the diastole extends beyond the electrical changes, because as we said, the mechanical has 1.5 times the time of the electrical changes. Regarding the excitability changes in the cardiac muscle, we have three important phases of excitability. First, absolute refractory period. Second, relative refractory period. Third, supernormal phase of excitability. As we know, during absolute refractory period, no response to any stimulus, whatever its strength. During relative refractory period, there is a response, but only for very strong stimuli, and the response is little. Supernormal phase, there is a state of exaggerated response so that subminimal stimuli can give response. The electrical and the excitability and also the mechanical changes. Looking to the curve, we will find that absolute refractory period is corresponding to phases 0, 1, 2, and the very early part of phase 3. Regarding the mechanical, we will find that the systole is corresponding to the absolute refractory period, and it is correspondent also to phases 0, 1, and 2. Looking to this figure, we can find that the cardiac muscle, while it is in systole, it is in a state of complete refractory period. This means that the excitability of the cardiac muscle is completely lost during systole. So the cardiac muscle can't be stimulated during systole. So you can't obtain tetanus in the cardiac muscle, because all over the duration of systole, the cardiac in a state of absolute refractory period. This is different from skeletal muscle, where the absolute refractory period ends before the start of systole. So the skeletal muscle can be stimulated during their contraction. So skeletal muscle can be tetanized. This can't occur in the cardiac muscle. And this is physiologically significant, because if the cardiac muscle is tetanized, this causes loss of pumping function, failure of pumping, and this is different from skeletal muscle, wherever the continuous contraction or the tetanus is a common type of ordinary contraction during different life activities. This also the relative refractory period, which is correspondent to phase 3, and the supernormal phase, which is correspondent to phase 4. An important question: why action potential of the cardiac muscle shows plateau while that of skeletal muscle does not show plateau? The main answer here is the presence of L-type calcium channels in the cardiac muscle and its absence in skeletal muscles. Vasomotropism is a term that refers to effects on excitability, and we call substances positive vasomotropic if they increase excitability, and negative vasomotropic if they decrease excitability. Also, we have nervous factors. Sympathetic increases excitability because sympathetic increases heart rate, so it decreases the duration of the action potential, so it decreases the duration of the absolute refractory period, so there is increase in the excitability. And parasympathetic does the opposite, it decreases excitability because it increases the duration of the action potential, so it increases the duration of the absolute refractory period, so it decreases excitability. Don't forget this figure. There is continuously in all tissues inverse relationship between calcium and excitability. When calcium increases, excitability decreases. This is the rule in the heart and most of body tissues. We reached the end of the lecture. See you again in the videos of the cardiovascular system.